The medical profession is considered to be one of the noblest professions in the world. The practice of medicine is capable of rendering noble services to humanity, provided due care, sincerity, efficiency, and professional skill is observed by the doctors. However, today the patient-doctor relationship has almost reduced its fiduciary trust and has become more formal and structured. Doctors are no longer, unfortunately, regarded as infallible and beyond questioning. We are getting sued more often than not, so how can we keep ourselves safe from medical legal cases? Well, friends, that's the topic of today's webinar and series of uninterrupted webinars from Chess Council of India. And hello, my dear friends, I'm Dr. Rajesh Swarnakar, the moderator for today's webinar, and I extend you a warm welcome to you all this evening. So, well, corporatization of healthcare has made our profession like any other business, and the medical profession is increasingly being guided by the profit motive rather than of service. And although rapid advancement in medical science and technology have proved to be efficacious tool for the doctors in the better diagnosis and treatment of the patient, but they have equally, sadly, sometimes become tool for the commercial exploitation of the patients. Medical law is undergoing a massive change, and on the other hand, a well-publicized malpractice can ruin the doctor's peace of mind, career, and sometimes even practice. Let's remember that the law, like medicine, is an inexact science. One cannot predict with certainty an outcome of cases, in fact, many a times. And it depends on the particular facts and circumstances of the case and also the personal notions of the judge concerned who's hearing the case. And the axiom you learn from your mistakes is too little honored in healthcare, as we all have experienced. You treat 100 patients and they have all recovered. You do one mistake and maybe you cannot escape the law. So the best way to handle medical legal issue is by preventing them. And how can we do that? Well, I have tried to make a short presentation on what should be our code of conduct and how can we at least try to prevent it. And this will be really good and will be an educative webinar for the young who have started the practice, and also for those who are in the practice and must have had some or other experience of medical legal that they have faced. So again, thanks to Chess Council of India for this webinar, that how we pulmonologists can try to be medico legal safe. We have got excellent panelists in this webinar like Dr. Madhur Joshi from Jaipur, Dr. Vibhu Kawatra from Delhi, Dr. Kinjal from Mumbai, Dr. Samadarshi Datta from Kolkata, Dr. M Manimaran from Chennai, and Dr. Koushik Muthuraja from Chennai. Some of them have also some legal education, so they are doctors and also have legal some training in their achievements. And I really thanks CCI Chairman Trustee Dr. N.H. Krishna and Dr. Narayan Pradeep for choosing this topic, and thanks to CCI Webinar Coordinator Dr. Vijay Kumar who also spoke to me on phone and tried to check out the flow. And actually, kudos to you, brother. You have been actually dishing out actually very good webinars with very, very innovative topics, of course, like this. I also thank CCI President Dr. Ashish Dubey and also Dr. Anil Maske, the CCI National General Secretary. So this will be a short context that I would try to give it to you at the start. And at the outset, I'm not being devil's advocate, but prevention of medical legal problems can begin if suppose we learn to put ourselves in the patient's shoes. It is not difficult to understand why medical legal situation arise. So I put the points like ABC of prevention of medical problems. It begins with awareness. So we should be aware, especially in a mishap situation, maybe it a chest trauma or any other adverse outcome of interventions. Think of possibility of litigation and act accordingly. Early attendance is vitally important. For example, if there is a patient with chest pain or massive hemoptysis comes to the hospital and is not attended to by any doctor early, the problem can start from that and there. Also, early attendance to the patient's complaints in the nursing home is also important. So when patient comes to casualty, everybody wants to be seen as soon as possible. You should have your junior. If you're not able to attend, then you should have your juniors who can attend, and of course they should all wear actually aprons to have a bit of security in the minds of patients who has come, who's quite panicked in that situation. The behavior, the rude behavior of the doctor or staff is an obvious cause. But it may not be just behavior, indifference to the patient's complaint or not listening to patient's viewpoint. The problem can start in fact later if any of your staff and not even yourself. So just be polite. We know that patients and their relatives are in distress when they come to hospital. They may behave erratic, but you have to keep your calm and be polite at all the times. The communication, so if you talk of C, communication, consent and certificates. So by communication, we try to inform, instruct and persuade the patient. We also hope to inspire confidence, and this can only happen if you are able to explain to the patient the need for treatment and how we plan to impart it and the risk involved. But we also must not forget that the communication should be a two-way affair, and we should allow the patients to communicate, and this can be the crux of prevention of medical legal problems. Let them ask questions, give them time to absorb what you are saying, or you ask if you have understood or not. So communication has to be clear and effective. Take time to ensure that your patient understands their diagnosis, treatment and medication plans, and then check their understanding by asking them to explain what you have just said, just to check if they have understood what you have said. And this ensures instructions are properly followed and demonstrates your care towards the patient. The consent is a cornerstone of any medical legal problem. Informed consent involves voluntariness and capacity of the patient to give consent, as well as knowledge or complete information to the patient regarding the type of treatment as well as the risk and alternatives. So you should discuss all these things when you are asking for the consents. About also certificates, we are too often being approached to give certificates of some sort or other, and always remember that certificates for medical legal problems, you should be a bit cautious, because giving a false certificate is a criminal offense, and it is always important to identify the person you ask for, some also birthmark or take a sign on also certificate that you have just given, as well as not to get pressurized in changing the facts. There is an example of a doctor who preponed the date on certificate of elective appendectomy on patient's request, and this landed him in jail because as the patient had actually committed murder before getting admitted to his nursing home. So this has happened. These are the cases that has happened. So we should be cautious, because at that time we may be pressurized by the patient or the relatives, and hence it's very, very difficult to say no at that time. But you should always persevere and be just persistent in what you want to do. Documentation, document, because what is going to be there in the court is only document. The patient is gone, the time is gone, what it remains is the file which you had filled at that time. So, and it is in the code, they say that if you're not documented, you have not done. So, documentation or records are mirror of our action in the court of law. Records should be correct, complete, contemporary and chronological, and they should correlate when recorded by various doctors. Made up records can easily be made out and can be held as criminal forgery, so don't do that. Good records not only help the patient's treatment but also come as handy as our defensive shields in court of law. So when you take rounds, it's often that our juniors basically do this documentation, but at least see sometimes that what he has written and see that everything, whenever you have seen the patient, is all recorded, ordered, and all treatment you have given is recorded in the file for any of the test. Ethics, empathy, explanation and equipment. So ethical treatment and empathy towards the ill patient always hold us steadfast in any medical legal problem. When things do not go as per patient's expectation, it is important to offer true and correct explanation to the patients, and this helps them to keep their faith and confidence in us. Having proper equipment for backup is very, very important. For example, even if you are doing a skin prick test, you should have all emergency measures tray there, oxygen cylinders, pulse oximeter in the hospital is a proof of our intention towards the duty of the care and should be there at handy if suppose patient goes bad. Finances, and it is very often seen that many times exorbitant charges or charges which patient feels are exorbitant. It does happen that we know that we can justify charges, but patient feels that it is exorbitant. It is always good to talk with him why it is exorbitant. Maybe you can quote the cost of the equipment, the also expertise, and because this can trigger off medical legal disputes, hence reasonable charges and proper explanation are always warranted. It is taken care of in any corporate hospitals, but in small nursing homes, doctors have to do this financial counseling. And hence it is always good to be transparent with the patient that what he is going to spend on his treatment. Goodwill. It is not only important to have goodwill among patients and relatives, but also among your colleagues and the community at large. Any of the politicians that come to you, you should basically strike some friendship with them. Any of the authority, police officer or some other stature, comes, you should try to oblige him, because when there is actually a situation in which his help is needed, your goodwill should be such that basically you can call for help, and that help can be much more costly than your fees. So don't also actually sometimes forego your fees for treating these patients. What they want is a bit of respect, but try to actually earn this goodwill so that you can use it at an appropriate time. Very, very important is not commenting unnecessarily adversely about previous treatments given by a colleague. This is a strict no, because this is a point to remember in this regard, because in many cases we know that he might have not done up to your expectation, but because of his deeds the patient is with you. So basically instead you should thank him. It also depends that in remote areas they don't have the equipment and they depend on the clinical skills, and they will not have TB, he was TB out, so he must have given a treatment of TB or so that doctor must have treated a case of cancer as TB. But do not even at that comment, do not comment unnecessarily on this thing, and this is a strict no. Help. So one should not hesitate to seek help when needed, as well as second opinion whenever deemed fit. So it does happen that if you can judge that if a patient's relatives is not happy with your treatment or is trying to question your treatment, if you're confident, basically you should ask them that if so they would like to take some second opinion, it's okay, and always take actually second opinion of actually one of your seniors, whomever you know, or then you can go there, you can give them choice to be called and see the patients. So it actually helps you in, of course, in their mind to see that how is the patient, and basically a person who's also repeating the same facts as you. This actually gives them some of the comforts. Help also refers to the helping staff to a hospital, junior doctors, nurses, even IABIs, because they can land a doctor in trouble by inadvertently wrong comments about treatment or by hurting patients by their behavior. So it is always of not you but your team who's actually handling the patient, who should be polite and should not try to have conflict with a patient and the relatives. So a proper counseling is actually very, very important. Investigations, while treating a patient, proper biochemical or other test needed investigation should always be carried out. You should advise proper test. It may happen that he may not do it because of the finances if you're in the private practice, but at least put those investigation, advise these tests. He may do it or not do it, but this will prevent further litigations. There are many cases where courts have held doctors negligent for not resorting to investigations on time, which could have helped in diagnosis and treatment. So use your knowledge, and in this and in a patient's, you should advise proper investigations which are actually well indicated at that point of time, and also put it in the file. Judgment, very important while treating a case. A careful and considered judgment is vital, and of course correct judgment comes from knowledge, so you should update yourself. I'll tell you my example. We got update up-to-date subscription. In fact, it's an app which has got up-to-date information about treatment, and I have given it to all my team. It's a small app that's on mobile, and still now I refer sometimes when I have some when I also have some confusion, or also want to know what is the updated point of care of that particular disease. I always take help with up-to-date, and of course read applicable guidelines, preferably Indian if available, because if you are done as per the guidelines, then it is good, and then it will help you in the court. And giving strong references for your given treatment can help you in the court. So all this is very, very necessary. About knowledge, to use proper judgment, one needs proper knowledge. So again, what I have just reiterated, that updating ourselves with the newer important developments in a field needs no emphasis, and if followed, these easy to remember guidelines should enable us to avoid medical legal problems. But finally, one must agree that we also need and always have some time and the luck. And it's my experience that the luck comes with the good karma. Try to do good, keep your intentions of giving best treatment, help poor and needy patients. So this is a small code of conduct, even accountability of hospitals. So hospitals' liability with respect to medical negligence can be direct liability or vicarious liability, what we call. Direct liability refers to the deficiency of the hospital itself in providing safe and suitable environment for treatment as promised. Vicarious liability means the liability of an employer for the neglect act of its employees. So as we said, you're just as good as your team. So an employer is responsible not only for his own acts of commission and omission, but also for the negligence of its employees. So as long as the act occurs within the course and scope of their employment, so accountability of the hospital is there, and it applies not only to doctors but his team as well. Just a note about common errors by medical profession. Patients who, because of a feeling that they were not heard, that their needs were not attended to, and that nobody seemed to care, and as a result, a bad outcome resulted due to a mistake or negligence of the doctor. Some of the instances where errors do happen by medical professionals are as follows, like avoidance. So this compassionate gesture counts. Always be compassionate, and this gesture will always count. If a hospitalized patient has basically a bad outcome, some physicians sometimes avoid making rounds in the presence of relatives, or they may not spend much time. Just thinking in the mind that now this is the gone case. But it is very important to let the patient and the caregivers to know that as a treating doctor, their problems are understood, and it is always a good practice to maintain the eye contact while addressing the patient and put a comforting hand on the individual's arm, a comforting touch. So basically, you should not shy away even at that time when your patient is dying to have actually good counseling with also patients or relatives. Defensive medicine. So it is better to avoid practicing defensive medicine, particularly when affordability is an issue. So we sometimes see the pocket of the patient and then advise the test. As I have said earlier, you have to write what are the advised tests for that patient at that point of time and not shy away, because after that victim is very likely to complain. Moreover, it amounts to medical malpractice, advising unwanted or even not advising tests when they are needed. So this is very important. Inadequate follow-up. There are instances when test results are not received by the ordering physician on the occasion. Patients do not follow through with the test as directed, or the results come in are filed away before the physician reviews them, and the patient is not briefed about the findings. It is very essential that physicians and their staff are able to track the status of these orders to make sure that none are overlooked or forgotten. Always go through the file, even the follow-up when the patient comes. You try to see what were his previous investigation and try to put a link to your treatment. Another aspect of care needing is better follow-up involves referrals to specialists. So if you feel that he would need other specialists, maybe look, then you should order it and you should ask for it. If you see that you've got some limitations of some test or equipment, try to refer it to someone who can help you in this. And all this step has to be documented, not only for preventing medical legal issues, but also for good patients' care as well. When also patients goes for discharge, write a proper follow-up date, plan, and if he doesn't show up, onus falls in him. But all this you should documented that you had asked him to come after so many days and he hasn't come. So always put this date in also your discharge file, and also some emergency numbers whom he can always contact. In the prescribing, in the prescription, try to avoid as far as possible handwriting prescriptions and utilize instead now it's very commonly available electronic medical recording and electronic prescribing. Be aware of drug interactions, write correct dose, days to take, and also stop those drugs. Some patients we find that you have asked for only a few days, but they are just taking the same medication for years together. So if it is properly written how many days he has to take and when to stop, that will help you in that situation. Also, of course, in the prescription, you should write when to come next, and as I said, the emergency contact numbers. Asset protection indemnity. All of us, it is vital to the survival of physicians to develop an asset protection plan of your hospital. In addition to professional medical liability insurance, not only does a malpractice lawsuit reduce the physician's ability to make a living in medicine, but also it can adversely impact or devastate both earned and invested assets. So you should remember that there are two categories of professional indemnity, which is personal or individual. So this will take care of the risk of liability of the doctor himself and his also qualified assistant. Errors and omission of the policy should be read. This and There is an institutional policy. This covers an institution, a nursing home or hospital along with its staff members. And if a doctor is the owner of a hospital or institution, it is recommended to take both individual and error policy, as the hospital institution is a separate legal entity and often can be made a party to medical legal case. So this is very important. You can in fact ask your CA or ask some lawyers that which of type of protection and indemnity you would have. It depends on what you are doing and whether you are doing interventions, whether you are basically a simple OPD or you see as OPD patients. So of course your premium depends on that. So you have to always also disclose all these things. About the clinical guidelines, adherence to clinical guidance is an effective way to improve quality care and reduce variation in care. Clinical guidelines have been systematically developed nationally and globally to assist clinical decision making, and you should always practice evidence-based medicine. And of course, medical negligence claims, and in court, these guidelines may act as a source of information, provided they are the product of a recognized body and are deemed reliable. They can be seen as normative standards and are used as explicit standards of care at the time of the indexed clinical event, and also to assess the degree to which a questionable practice was in line with the accepted standards or standard of care. Empathy and expectations. Patients want to believe they are the most important persons the doctor will see that day, and the doctor focuses 100% on them, although it is not possible. But while this is not feasible, taking time to think like a patient and understand the condition from their perspective can help in becoming more empathetic physician and build a better relationship. People are less likely to sue a physician with whom they have basically a positive relationship, even if something goes wrong. So remember this fact. Medical malpractice lawsuits are not quick. It can take years after an incident for a malpractice case to be resolved. Malpractice cases have to go through a long process, including discovery, which is the investigation process. It could take months for this phase alone. While in the midst of a malpractice case, one needs to stay focused on other areas of your life, the system, and also you should also support system which needs to be mobilized in the event that this happens to you, and obsessing over the case should be avoided. The medical malpractice stress syndrome is a real one, and it is experienced to some degree by all physicians who are used or who are sued at one point of time in the medical practice. So you should identify the potential litigant and you should take some risk management. A reasonable doctor should consider every patient as a potential litigant. It is to keep a doctor in constant awareness to stick to prescribed standard of care and avoid any adventurous attempt. Stick to the guidelines. A doctor should not ignore any allegation in any form, oral or written, whatever has come to his notice, and should be able to handle allegations with clear and firmness in an intelligent and sympathetic manner. We should also have some of our risk management plans ready. So when a doctor is working for a hospital, the defendant doctor should notify risk management department of the hospital whenever he receives some of the legal notices served to him. And of risk management employs a lawyer who specializes in medical practice, and of course the lawyer will help the defendant doctor through the process. Moreover, becoming educated and understanding and your preparedness is actually what will help you in also reducing your anxiety. So we all have faced is a media trial. These are all extortion practices that are very common now. Every Tom, Dick and Harry channel comes, and this is often referred as the fourth pillar of the democracy. However, it has no right to present the facts of a case in an unfair and also prejudicial manner. A doctor cannot become a victim of malicious or defamatory reporting. A doctor should not be silent and should also rebut all the allegations that has come in the press and media. And of course, doctor can take help of their professional association to convey the facts and support to resist a trail by of course media and Indian Medical Association can come handy, and you should be always be touch in your of your also local branch, go and attend their activities, have some relationship with them, and because they can help you in such unfortunate situations. So we have got laws which protects us. It is not that we should practice in fear. There are laws which are there which are very strong that will protect doctor. So the Supreme Court has warned the police officers not to arrest or harass doctors unless the facts clearly comes within the parameters laid down in the Jacob Matthews case. This was a case that also we'll also discuss here in our panel discussion. Even a threat was given to the police officer that if they did not follow these orders, they themselves have to face legal action. So make them aware of this. And even the Supreme Court went on to say that to prosecute a medical professional for negligence under criminal law, it must be shown that the accused did something or failed to do something which in the given facts and circumstances no medical professional in his ordinary senses and prudence would have done or failed to do so. The hazard taken by the accused doctor should be of such nature that the injury which resulted was most likely imminent. So the Supreme Court has attempted to remove apprehension that prevent medical people from discharging their duty to a suffering person. So don't be afraid. There are laws to protect you, and this is actually the contest setting and code of conduct that I wanted to tell you all, and all of this is by experience, and by I was laid down some of the common things that we can do. And post this, I would like to also tell the audience that if they can ask their queries or questions, and we will take it at the end of our panel discussion. I would request our panelists to now open their videos and be apparent and try to be brief and specific to the queries that are going to be addressed. Of course, now. Thank you, and we now begin our panel discussion.
A very good evening to everyone. At the outset, I would like to thank Dr. Swarnakar for his kind introduction regarding the theme of this evening. I would also like to thank Dr. Krishna, CCI and the entire team, Dr. Shivani, Dr. Atri, and all the people involved in the background. So just to begin with, I will be discussing a few cases that would predict a bird's eye view of potential medico-legal issues in pulmonologist practice. So we will be discussing in the end what could have been done better to avoid litigations in such cases. Well, the case first is a 70-year-old male with a 30-pack year smoking history, and he was referred for COPD and lung mass evaluation. During his OPD visit, I found his vitals to be a bit unstable with irregular pulse. To compete with, we are always eager to do most of the bronchoscopy and biopsies done on OPD basis so that the patient's cost is saved and the patient's time is also saved. But I suggested this patient to undergo an inpatient evaluation rather than an OPD evaluation for a bronchoscopy and biopsy. So this is what a consent form that I use looks like. It is printed in both the languages, that's English and Hindi, that my patients usually do understand. I try to cover all the complications in those consent form, whether it be a common problem that patient might face during the procedure and the uncommon one as well. So the next case, I would call it as a Seldinger's jinx. We all have been working in the ICU. So here is a 50-year-old male who was on mechanical ventilation and requires a central line. Well, we should be aware about what complication is and what negligence is. So just an example, if you can see the X-ray, the IGV was cannulated with a central line and it went to the subclavian vein. A hematoma, a hemorrhage, a turned central line is a complication. Well, on the other hand, a left guide wire in the IGV becomes a negligence. The third case is the fitness for surgery that most of us are being referred to. Here is a 70-year-old male with severe COPD. He had a fall with right hip joint dislocation, so the orthopedician wants to operate on him. When he was referred to me for fitness, he was having MMRC grade 2 dyspnea. He had occasional rhonchi. His PFT showed moderate obstruction. His chest X-ray was shown to be the same as on the right-hand side with hyperinflation. So I advised that he can be taken for surgery, but with due risks for exacerbations. There can be a few spatial considerations, especially when you are giving a diagnosis on a medical certificate. You can, for example, I would say during the COVID era, there were many patients who were having bilateral viral pneumonias on the radiographs, but their RT-PCR were negative. So I always make sure that I do not label them as of having COVID, but I label them as of having atypical pneumonias. This is very important. The next comes the air travel. We all must be aware of the guidelines, whether it is a domestic flight or an international flight. The website clearly shows most of the illnesses that requires a doctor's certification for a particular illness in a patient to get him on board to fly. You would be surprised. These are the excerpts taken from a airline website, which clearly mentioned about a few of the respiratory illnesses and the duration and when they will be taking a doctor's fitness to fly certificate along with it. I was also surprised for the first time when I came to know that the oxygen supply in the flight is usually 4 to 5 liters per minute. That is almost equivalent to an oxygen concentrator. So this was a list on the airline website that had showed what all illnesses requires the medical certificate or a fit to fly certificate, and that has to be generated within 72 hours. I was also surprised to note that any patient who has had a history of COPD exacerbation or any exacerbation of underlying lung disease has to also submit a arterial blood gas report that is within a month's time of his scheduled flight. Then comes the patient who would like to travel for a Char Dham Yatra. That comes under high altitude travel. You have to be very cautious with them. You have to advise them according to their underlying illnesses as well. Coming on to my next case, he was a 45-year-old male with respiratory failure, bilateral pneumonia, thick wall cavity. He was in MODS and he was already on empirical ATT. He was referred to us for on a mechanical ventilation and on multiple vasopressors. I was suspecting malignancy in this patient, but it was too difficult for me to give a tissue diagnosis, and he was declared without a confirmatory diagnosis. So these are the patients where you should take multi-specialty consultation, especially oncology, cardiology, nephrology, and whatever is available in your hospital. You should always be ready to give them a case summary just in case if they want to go for a second opinion elsewhere other than your hospital. Then comes the documentation and counseling. This case, a 60-year-old male who visited to me in my OPD, but he was too tachypneic, too dyspneic when he was walking into my OPD. He had a typical viral pneumonia and ARDS type of picture. As soon as I admitted him in ICU, he was in shock and he was declared in 48 hours. We had proned him in that 48 hours. We gave them an option of ECMO. But all that has to be documented well and explained well to the relatives. Okay. Otherwise, the relatives would say that we came with the patient walking and now the patient is no more. And this is very important. The blame game. She was a 25-year-old female who was a new pulmonary tuberculosis case, and she developed 7 days during her treatment. She developed drug-induced hepatitis. The patient's relatives came to me, galat dawa de di, महंगा test करा दिया, CB NAT करवाया था. So, your answer should always be regarding your colleague, because your colleague always does whatever best is for the patient. So my answer to her and to her relatives was that the medicine given was in accordance with any national guidelines and it was the best regime. Okay. So you have to stop the blame game whenever you are practicing in a private center and you have your colleagues around you. So another case, this was a very interesting case. On a Sunday evening, I was with my family, a 50-year-old male NRI. He visited my dentist friend for an implant treatment, because it's more much cheaper than what it was in Australia. So he was from Australia. So the dentist called me that my patient is coughing. I was doing a dental procedure and it slipped, and he has a flight day after tomorrow. What can be done? So I just told him get an X-ray done and send him to my emergency. So without going for a CT scan, I had to do a bronchoscopy. I found the dental implant part in that, and it was easy that it was just correctly diagnosed on X-ray, that we could have retrieved this foreign body from his bronchus. So in the end, we all are very worried about WhatsApp consultations and online consultations. So here is just an excerpt. This was the same patient on the left-hand side that took the fitness of fly from me, that he wanted to fly to Germany, Berlin. So from Berlin, he reached Berlin. Although I never wanted him to fly because he was in ICU and type 2 respiratory failure. It was very difficult on a non-invasive ventilation. So from Berlin, he messaged me and he was calling me on a video call, giving me audio calls on WhatsApp, saying that I'm not able to get any consultation. It's taking 3 months for his appointment, and none of the pharmacies would give him the treatment that was being prescribed by me on an emergency basis. The right hand side, there was another WhatsApp. I never saw this patient, from another patient, and he just messaged me his reports that I'm having this and this problem, and it's difficult. It would take 6,000-7,000, and he's living around. He's staying around 200 kilometers away from my hospital. So if I can just do a consultation and advise him what he can do for his symptoms. So my answer to him was that he should at least go to a nearby doctor. At least I can talk to him, and then maybe he can guide him better than me. So just a take-home message in the end, we all should be aware about the legal standards and obligations. We should always follow the standard of care. We should always have informed consent and documentation practices in our habit. We should always be prepared for the risk management strategies. We should always be aware about our professional liability insurance, quality improvement initiatives, and legal consultations when we have to take them. I think on board we have our doctor colleagues who are also advocates who can guide better than me when to do and what to do in such situations. In the end, I would just like to say that the purpose of education is to replace an empty mind with an open one. Thank you.
Thank you, Dr. Madhur Joshi, for your practical experiences, cases, and it is related what I had studied in my code of conduct lectures. So I think we'll go for the panel discussion, and I would just come to Dr. Vibhu first. He had some tips about and adding to what has been already said. Dr. Vibhu, would you just like to elaborate something that
Yeah,
we have
I
missed?
actually made a few points regarding the criminal procedure and stuff. So first thing I would like to put forward is that this Consumer Protection Act, which came into force in 1986, and it was basically the judgment in 1986 where the IM was against this Consumer Protection Act, but it was allowed. So we need to understand that Consumer Protection Act covers not your criminal negligence but only your civil negligence. So one thing is this. The second thing is, when it comes to the criminal negligence, it is basically the attempt to murder and the 304 section which comes into force. So for that, we need to understand that there was a famous case which was Suresh Gupta versus Government of NCT of Delhi in 2004, and in that case, it was the net point was a higher degree of immorality and deliberate wrongdoing must be proved in order to charge a doctor as a criminal negligence. So I'll just tell you a short history of this case. Now what happened in this case was that the patient had nasal deformity and the patient was being operated upon. Now here, instead of using a cuffed endotracheal tube, the doctor used the non-cuffed endotracheal tube, and eventually the patient had aspiration. The patient died. So the parents, the relatives went for a criminal negligence thing. So here, it was not something which was, the intent was clear, the things were fine. it was a bit of a negligence, but it was not as a higher negligence. Now, who decides this higher negligence? That is another point, because here you have a medical board and the your council and all, which does give its thing that okay, fine, this is a part of. So what they give is that whether it's a part of a normal complication or not. Eventually, it's the judges who decide, who are not actually the doctors. Another point was the Jacob Matthew case. For all criminal negligences, let's be very clear. The Jacob Matthew case is the benchmark, and it was decided by the three-judge bench way back in 2004. It was Justice Lahoti who was the Chief Justice of India. So the point was very, very clear that it was that you have to have a Bolam rule. Now, the basic rule was a man need not possess the highest expert skill at risk of being found negligence. It is well established law that it is sufficient if he exercises the ordinary skill of ordinary competent man exercising that particular art. So I think you covered that part where you said that okay, you need to cover the basic stuff, but you have to do something which is right, and which at least is expected out of you, the minimum thing which is expected out of you. So there have been several cases which have been there, and one case I would like to put forward is that of it was Dr. Ashok Lada versus the state of Madhya Pradesh. Here, you had a patient who had a cancer. He was a cancer patient, and he was in immense pain. The splenectomy had to be done. So the doctor did the splenectomy, but while doing splenectomy, he accidentally cut the small gastric artery, and the patient went into shock and he died. Now, autopsy was done, and where the small, artery was found to be cut. The point was that it was in immense pain. The patient already was a cancer patient, and fine, you can understand a gastric artery being cut by a gastric surgeon. It is something where, as a normal doctor also will think, okay, this case is actually a negligence case. But he was given a clean chit. The reason was that his intention was right. He was relieving of the pain, and this is a normal complication of a procedure. So this is something which has to be taken into account. Another case was that of Dr. Namita Agarwal. Now, here in her hospital, because this is a hospital setting, all of a sudden a patient comes to the hospital, brings a HB report of 8.9. Now, just remember, 8.9 G3P2 patient comes to your hospital, and she is in labor. And they don't give you a history. That very often happens. And the patient is in labor, so eventually the patient had to be taken up for a cesarean. Now, the last report which is reported was 8.9 hemoglobin. The patient actually had and the blood tests were done, but there was no point, there was no time to wait for the reports. The patient was taken directly to the OT, and patient eventually died. And she went into shock and she died. The report finally which came was less than 7 grams. So ideally, the blood transfusion should have been given. But then here again, this case went on, and eventually it was found that you had no time actually to do the thing. Now here, one thing was caught was that the patient was told in the previous hospital that the patient requires the blood transfusion. So this, I think, a lot of us who have their own setups could understand that these kind of things happen, and when they reach the emergency, it's just that you may not have time. It's like we do bronchoscopies. So all of a sudden, a patient comes when he's completely choked and is getting cynos. Now you don't have time to look at the PTINR, or you just take the patient and you just go for a bronch and try to remove the blood, the foreign body. But what if the patient dies? What if the patient was actually a patient who had some bleeding disorder? So you don't really know. So the thing is, the Jacob Matthew case had a few things. A private complaint may not be entertained unless the complainant has produced prima facie evidence before the court in form of a credible opinion given by another competent doctor to support the charge of rashness or negligence on part of the accused doctor. So now the modification has been done, and it's mostly actually the council or a panel of doctors who have to give a report on this. And the investigating officer should, before proceeding against the doctor accused of rash or negligent act or omission, obtain an independent and competent medical opinion. Now, so this is again important. The patient has to produce one opinion, and the investigating officer again has to, appear, has to present this. Another point is a doctor accused of rashlessness or negligence may not be arrested in a routine manner. Now, this is very important unless the arrest is necessary for furthering the investigation or for collecting the evidence. So now this becomes a bit of an open-ended thing, but the thing is, as per the law, you cannot be just arrested despite your first two conditions being fulfilled. Still, you may not be arrested. So this is something which is important because we are all scared of going to the police station and all. So this thing is a very basic thing. Another thing was that even in a normal case, it was told that the civil proceedings was there. There was this bus driver who, for saving a child, eventually landed up killing one more child. So this was a case which was there with the state of Karnataka. So now the intention was not to kill. So
Yeah.
so eventually the person was relieved of his charges. So thing is that here again the doctor charge comes into force. So you want to say something, then I can put in more. I have just two
I,
more points.
so I think so we do understand that basically you have to have the intention of a treatment which should be correct. And of course, complications can happen, opinions can differ. So all these things doesn't mean that you would be basically sued, and we should not be afraid. Afraid of that. I would actually come
Now,
to Dr. Joshi.
one thing, sir, I would like to put forward was where this Jacob Matthew case didn't favor the doctor. Now, this is very important for us to understand. This was a case where a gynac conducted an operation in a patient where, knowing that this patient might have a complication of PPH, the center was not well equipped for the to handle a critical case. So now we need to understand, here you have a patient who at the time to be shifted to a higher center. The gynac was qualified, everything was fine, but then the center was not well equipped. So coming to us, suppose we are dealing with a kind of a case where which can bleed, and we are doing it at a center where we don't have a blood bank or a ICU available for a bronchoscopy. Then that patient, in that case, the Jacob Matthew case is not going to save you. Last thing I want to put forward is, which is not a very good news, the new Bharatiya Nyaya Sahita, which came in 2023. Now, here we need to understand that the previous IPC section had that you have to go for something which is special or higher than the normal insult to your profession to get into a criminal offense. While here the person can be prosecuted for criminal negligence, and the higher than the thing is has not been removed. The thing is that while formulating had only made a distinction in the punishment awarded to medical practitioner and not to the nature of the act. That is, the higher degree or gross or culpable thing has been removed from the Bharatiya Nyaya Sahita, which means that for the criminal procedure, that higher thing of doing a negligence has been removed for the doctors. That is one thing which we need to understand. So it has actually worsened our situation from where we were before 2023.
Right. Okay, Vibhu. So thank you for your perspective on this, and certainly we'll learn. And as I said, that the laws are also changing, in fact, and we have to keep track of all these changes and act accordingly. I would come to Dr. Joshi because he's in transit, I think, as we are all, in fact. So people say that if you take, I think this has consent very good, then we would be saved. So I think I would like to ask actually Dr. Joshi, what are the guidelines for taking medical consent, and if you take them properly, would you be saved in the court, or it can be thrown out of the court? Because we have seen that so many consents have got some conditions, and consents with conditions are not seen well by the court.
Right. So thank you very much for that question, sir. So when it comes to obtaining consent in medicine, there are several important guidelines to follow. Okay, so it has to be an informed consent. The patient should be well aware about the consent, and I think even the relatives must be a part of it, so that the consent is fully given. If at all a patient is unable to give his consent, there has to be a best next kin who is of course related, so that he can give a consent in his case. The voluntariness and obviously the documentation of same is very important. The ongoing consent can anytime be reverted. If a patient feels that he has given a consent or not given a consent and he wants to change the consent part, he should be allowed to do that. It should well be documented in the languages, whichever is understood in that local area, be it be English, Hindi, or any other language of that area. And we should respect the autonomy. We should respect whether the patient's right to make decision about their own care, even if healthcare providers disagree with his decisions. Respect for patient's autonomy is his fundamental right. Okay, so there can be some special situations that can be taken care of, but obviously it has to be well written, well documented. And yes, these days even video recordings of the consent are also becoming a very important part. I think you all will agree, and even my seniors would be better to comment on this. But I think it is very important to even video record whenever it is possible.
We will also take some audience questions, because there is a question about what should be the ideal consent for also doing basically bronchoscopy. So, do you have some formats? So, I think we have got so many formats. Do you also want to just comment on that? Anyone? So, there is a question, because we may not have time. So, I'm also somebody taking the questions of the audience, and of course, bronchoscopy is much often done by us. Do you have some special format of this which can be stick to? Anyone who has got? I think that Dr. Joshi has gone, and there was also disturbance around him. So yeah, he's there.
Yes, yes. So I think it's very, we should be very specific about all the complications, be it common complications or uncommon complications. Whether it comes to a simple pleural tapping, it should always be USG guided sustenance. Then we should always have a different consent forms that states what procedure a patient is going on. Be it any bronchoscopy or a thoracoscopy or any other ICU procedure which is invasive, you have to take a consent, and there should be different consent forms for different procedures that well explain whether there what all common complications can occur and what all other rare complications should be well documented in that. And again, as I said, it should both be in English, Hindi, and whatever is the local language. If you can do that, that would be best part.
Okay, thank you, Dr. Joshi. I think we'll just spare you for a while. I know that you are in transit and you are a bit disturbances there around you. I would now just come to Dr. Maniraman. In fact, that we take all our what we call code of conduct, and we take all the precautions, but we still get sued. So, what are the variable defense available to the doctor when he's sued for medical negligence? How they should not panic and do the also defense accordingly, one by one, step by step. You're on mute, Dr. Maniraman.
Sorry.
Okay, Dr. Maniraman, you are again gone on mute.
Can somebody follow? Just I'll come back.
So I think just to a follow-up question of Dr. Joshi, which was there. So I would ask, Dr. Datta, what are the common fallacies which are made in just taking consent? If you can point out those which of course can be avoided.
Yeah. Thank you, Rajesh sir, for this question. And at the outset, I would like to disclose that this is my debut webinar with CCI, and I must express my gratitude and thankfulness to the whole CCI family. So actually, I don't have any legal education, so I am a learner here. I have come here to learn, and in the process of learning, I have just come across a few points which can be taken as the common fallacies in the consent process. So first of all, many of us think while getting consent for a procedure that it is a trivial procedure and consent is usually not taken. So that is the first and foremost fallacy we often commit. Then the consent of a relative we often take instead of the patient, but it is well documented that when the patient is a competent one to give the consent, then we have to take consent from the patient himself. So the next one, the consent, if taken from a minor or any intoxicated or any inebriated patient or somebody with unsound mind, that won't be valid. So that may be a fallacy. Then the next point could be if we take a blanket consent, say if the patient is getting admitted and we are taking a consent in the form of that I am agreeing for all the procedures and all the investigations during my stay, this is not going to be valid. So that should be specific. A blanket consent is not valid. For each procedure, if we are doing some repeat procedure or fresh procedure afresh, the fresh consent to be taken, the older consent is not going to be valid. Then, even if the information is given and the patient agrees, but it is not documented. So you have pointed out in the point D, the documentation is very important in this case. It has to be documented. Then many a times we miss to sign the document, we doctors. So the consent lacking the signature of treating doctor is not going to be valid. And consent taken without the sign of witness is not going to be valid, or if it is not video recorded. And a few times we tend to alter the consent taken once. So that is strict no. The alteration and addition or deletion of any point made by the patient while doing the consent, signing the consent form is not allowed. And then some communication barriers like language barrier or ignoring patient's cultural and personal values. These are also some fallacies which are made in consent. So these are the points which I could find.
Yeah. Apart from that, basically, I've also seen actually some of the doctors take audio-visual consent, especially for I think some of the procedures, or also during all counseling. If suppose patient is quite sick, is it okay to take audio-visual consent? People have some audio device or some camera, and they start recording.
Yes, I think if it is recorded and well documented in the court of law, it is acceptable in some special cases.
Dr. Vibhu, what's your opinion about this audio-visual consent when he is counseling a bad patient?
Consent is always better, no doubt about it, because if you
the device is very simple to take. So if you have a device which is simple, you can have it.
Yes, but one thing is that your consent has to be in a language which the patient understands completely, and you have to make sure that you don't miss any of the points. It's very easy to say that when I do pediatrics also. So when I say that suppose a child comes to me with say acute diarrhea. Now I normally I've seen a lot of pediatricians writing a line, danger signs explained. What do you mean by danger signs explained? If the child goes into severe dehydration, then the child may require admission and all. So you have to be clear. The code of law is very clear that whatever are the complications or impending complications. So suppose you're doing a procedure, bronchoscopy or whatever, every point has to be covered. That okay, this can cause this can cause this can cause this. Because once you have everything documented, then only the consent is taken as valid.
Correct. So
and that may actually trap you. Just remember one thing, that may actually trap you. Your video recording may actually work against you because you miss the point. If you miss 1 or 2 points, you can actually be trapped with that. So it's a two-way.
Yeah, so you have to make points, and you can basically before doing it, basically you can have 1, 2, 3, 4 points if you're not so that you don't miss. But I think that is a very good practice, in fact, in ICU and also for also consoling a very bad patient, sick patients, because
Absolutely.
afterwards they do say that नहीं sir आपने बताया नहीं था कि this is the
No,
he's
no,
so
that is
sick. And
so that is not telling about a patient is not consent. Telling about a patient in an ICU setup where every day you're giving morning and evening rounds where you're telling that what's the condition of the
counseling.
patient. वो तो एक अलग काउंसलिंग तो एक अलग चीज होगी. That's a completely different game altogether. When you're talking of a procedure and you are having a video recording, so I think a written is much better because at times what happens when we are counseling orally, we might skip a few points and that may actually go against us. So it should be completely written, all things documented. Whatever procedure you're doing, just put 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Whether you have told that to the patient or not, he has signed it on that. That is important.
Yeah. Or again, come back to Dr. Maniraman. In fact, we had just lost your voice at the time. So, what are the variable difference available once? I mean, you have taken all those precautions, but you get sued.
So there are three differences available for medical practitioner. The medical practitioner has to prove that there is no existence of duty of care towards the patient. So, or in that case, medical practitioner treated the patient, then the medical practitioner has to prove that he has conducted the treatment to his best effort with the due care and course of treatment which he chooses to perform is suitable in the situation. So these things can protect medical practitioner. Another difference which is available with the medical practitioner is to prove that the patient did not suffer any injury from the treatment performed on him. So these things definitely it's going to help him. Sometimes it is not the medical practitioner is not the only one to blame for the injury caused by the treatment. Even after taking the treatment, injury is caused due to negligent act done by the patient also. In that case, medical practitioner has a valid defense against the medical negligence, that the injury is caused due to the negligence. For example, the patient mixed the prescription given by the medical practitioner or failed to disclose his medical history, and these things will lead to medical practitioner may be off the hook for any injuries can be the result.
So I think it would be better that we have got some insurance system or something in which you can basically give that case to them rather than be affected by that. And I would like to say you at that time that basically we have got this Indian Medical Association indemnity policy. So, and I also mentioned in my lecture that actually we should have one I think association that can back you. And we got an indemnity policy which also provides lawyer to you. So I think you have to just hand over your files and everything to them, and they will take care rather than you being involved in the thick of that, because it has been seen that all the cases are quite just basically very small cases, but then if we get all the anxiety, stress. So it's always better to hand over this to them, and then maybe at the later stage you can come and see. I think that is quite easy enough thing to do. And of course, what we call is basically you have to just maintain files. So I will just come to Dr. Kinjal Modi about this IPD and OPD records. What are the norms? Because we also neglect it. We do the things, but we don't put it in the file. Or consequences that can have. What are the good practices that actually you can have to have good documentation of OPD and IPD record.
Definitely, sir. Thank you for asking the question, sir. At the onset, I would like to thank all the CCI team, mainly Krishna ji, Dr. Narayana, Dr. Atri, Dr. Vijay, and the whole team who has been instrumental in organizing this whole CME, taking our attention from the pulmonary side to the medical legal side, which is also important nowadays. Pertaining to a question, sir, basically keeping the records is a very common question asked to us, that how many years you have to keep the records, what things you have to keep in the records, how to keep the records, all the things are very important. So first and foremost, remember, simple thing is IPD and OPD, two records are generally there. For any patient, you have to keep an IPD record for 3 years. That is for sure. OPD records, they say 2 years. And if it is a medical legal case, for example, if person has made a case out of it, you have to keep the record till the last final decision of that case is attained. So these are the simple things we have to remember. What are the details you have to mention in those things? Being a doctor, we are always in a hurry to finish off our things and put it haphazardly. Sometimes we don't sign the things properly, not put the date, not put the time. all those things are very simple things we find when patient is asked, patient is like pleading to us, doctor साहब क्या आप ठीक कर दीजिए, सब तब तक सब अच्छा है. Moment they come up against us and then they file a court case, all those things goes against you. So putting each and everything, see, legal field we can say is the most in the laughing manner we have to say is the most illegal way that they follow, we can say. You might not do things, but to write on paper. That's what Dr. Vibhu also said right now. In audiovisual consent, if you forget something, it will be taken on record. But if you write all those things, you might have say to the patient, that is perfectly true. So that is what happens with court also. They just check the records. So on record, everything should be fine. Seen by so-and-so doctor, so-and-so time, so-and-so things were done. Your physical findings, investigations, explain to the patient, counseling done to the patient, those small lines, if they are mentioned in your daily notes or on your OPD papers, makes a huge difference when it comes to a legal field, because then when the judges see all those things, the doctor has every day made the notes, had made up detailed notes, had mentioned that he has counseled the so-and-so person, so-and-so relative, explained them the prognosis, especially in the poor GC patients, all those things makes a huge difference. So these are simple things we can take care and avoid complications, sir. Thank you.
Yeah, correct. So that is the way, in fact, that we take the rounds. We've got RMOs with us. And I think we should just inculcate a habit in them that they would just record whatever we have said or ordered investigations. It should be just put in that file as well. And then also treatment that we have told. That's very important because we take the rounds and then we'll just...
I would like to put one point here as everything is mentioned. Okay, so most of...
more better.
One by one, yeah. Yeah. Yes, Dr. Vibhu.
If we keep in digital records, it will be more better. So that is what the law nowadays wanted. Keep the digital records are they can be retrieved also very easily. That is what the people want nowadays.
Yes, but one thing is there, Dr. Modi, that if you are having the digital records, everything is recorded with the date and the time. So the chance of you changing or trying to manipulate anything in the file later on is not possible. One thing I would like to put across is like all those who are listening, the audience listening, with the smaller setups. So with the corporate setups, whenever the patient goes for the admission, they have to sign a lot of papers. Remember one thing: any patient whom you are admitting, even if he is paying or whatever, you have to take a consent that I'm ready to be admitted. Now, this is something which is very important, which most of us miss. Like in our OPD, the patient comes, he pays the consultation fee, that becomes an impending consent. But here, when you are admitting a patient, he has to give a consent. Yes, I am ready to be admitted. So that consent has to be there. So every hospital, every small nursing home can have a small consent that I've been explained and the charges and everything, and that I'm agreeing to be admitted. So he may be paying you everything, he may be doing everything, but if anything goes wrong and goes to the court of law, you need to have the first thing is, did the patient accept or consent to be admitted? So that becomes a kind of a thing which you are taken aback all of a sudden.
Yeah, right.
Nowadays, actually, the hospital has that for first form basically, that when the patient is admitted now, first thing the relative signs is that form.
That's what I said. Most of the bigger hospitals are going to have it, the corporate and all. But the smaller, anybody having their own setups, that's going to be an issue.
For that. That's true.
Yes.
Yeah, but in that consent, it's actually a blanket consent. So I have seen the consent form of the hospitals, which actually takes a blanket consent. In fact, that is there any need to take? Yeah, so they would. So they would agree. That's not valid. In fact, that if you take a blanket consent for everything, that I would do surgery, I would do whatever I want during your admission. That is.
So the blanket consent is that patient has agreed to be admitted and to be treated for whatever is to be done. So that becomes now whatever procedure you do, for that you need a separate consent. So it's like a series. So it's like so now the thing is, you don't need to take a consent for putting an IV cannula. Let me be very clear. If you have taken a consent for the admission, you don't need to put. Otherwise, ideally speaking, you have to take a consent to put even an IV cannula.
W2. But then was CVP line, everything else we will take consent with.
Yeah, so we'll be doing what you call bronchoscopy, and if I'm doing a transtracheal also spray, so do you then just take a separate consent for that, because it's an invasive procedure? This is also invisible process. So, do you want to take another consent or?
You can put it in the same consent, but you have to
Yeah,
put it as a point. You have to. I mean, it has to be a separate point altogether.
Right.
Correct. Do we have also Dr. Muthuraja here? His name was there in the. Is he there, Dr. Muthuraja? Dr. Koushik.
He's on the flight. He's on the flight.
Okay, so I think we'll move further, and we will come to the menace of. And it has been mentioned that we also had to give consent on also telephone or the text consultation or also the WhatsApp. What are the points to be followed while actually giving all this what you call consent, Dr. Vibhu?
Okay, so whenever you're doing a teleconsultation, let me be very clear. The WhatsApp consultation should be avoided as far as possible. That's the first thing. Even if you're doing
so you have already seen the patient earlier in the OPD, and then if he's asking something he has got some allergic reaction.
I'll give you an example. Suppose the patient asks you that, fine sir, I've shown you at this time and now I'm having vomiting. So when you are saying, okay, you're having vomiting, and suppose you have to give ondansetron, ideally speaking, now I'm going by the law. Ideally speaking, that ondansetron has to be on your own prescription pad, written tablet, ondansetron, patient having vomiting, ondansetron, SOS, stat, and then SOS. You have to sign, stamp with the date and time, and you have to mention that it's telephonic consultation. Then send a the shot of it to the patient. Ideally that should be done. So if you just type in that, fine, you take a tablet ondansetron and this is done, it doesn't work. Another thing is, a lot of times, because I have a small setup, so what I've seen is a lot of doctors just saying, go and get एक Rantac का और Perinom का injection लगवा लो जाकर पास में. A patient comes to me and shows me, okay, this is written. I cannot give, because remember, at the end of the day, legally speaking, I'll be in a doc. That doctor won't be in doc. That doctor will say, I never wrote this. So that would be another thing which is there. Whenever you're writing a teleconsultation, make sure, now here it is important, your date and your time and that mention that it is a teleconsultation should be completely there. Because nowadays, it's a trend of the digital prescriptions also. We most of us have digital prescriptions. So whatever prescription you are giving, if it's a physical consultation, it's fine. But you have to make a standard thing that, fine, for every telephonic consultation, I will mention it's a telephonic consultation. And in the last line, it's always important that whatever, suppose I do a telephonic consultation for an ILD patient, then in that prescription, I have to explain the various danger factors or the risk factors. So if I have to say, suppose a patient says the saturation. So as per the patient, the saturation is this much, and that should be documented. The patient, when he puts across that, okay, this is what is there, either you have to record your entire thing, the video recording, or everything has to be on the document. That patient has to write that, fine, doctor, my saturation right now is 92%. So suppose you are doing just a normal WhatsApp consultation, you're not recording it, and the patient says, doctor, right now my saturation is 92%. How does the judge know that whether you asked or you did not? So everything that has to, so you need to make a small form that, okay, what's your saturation, what's your pulse rate, what your this, whatever the patient can give you, so that it's easy for you, and put all that thing on your prescription. That, fine, I've asked for the thing. And suppose now we were doing the COVID consultations. Yes, teleconsultations, we were doing a lot of COVID teleconsultations. So in that, you have to mention, okay, current saturation is this, please watch for saturation. In case the saturation falls anytime, say below 92%, you just make a small criteria, 94%, apna bana lo chahe. The thing is, just rush to the nearest emergency. So what happens is, you give time. The patient, obviously, if you're going to write that if it falls below 94, you rush to the emergency, patient will not go. He will go once it goes below 90. So you play it safe. That is the main thing. So whenever you're doing a teleconsultation, remember your liability is much, much more than a physical consultation, because you are depending too much on what patient is telling you.
Right. So there are the guidelines for this teleconsultation, yes. And I also remember that API and Indian Society had joined, but
legally speaking, all those guidelines. Yes, that was valid only during the COVID
only
time.
for 5 years or something. So I don't know whether it is gone because it was made in 20 or I think at the end of 2019 because of the COVID. I don't know whether they are valid now also. But
So
what I
it
was
is.
talking only about WhatsApp. So basically WhatsApp text consultation. That thing is it was something that you have to be cautious enough. You can at the most just over the OTC kind of medication and ask him to just consult basically doctor who would be just nearby and do not go overboard on really solving is everything because of we don't know the cause. For example, if there is a he's just asking for basic chest pain, so basically it can be also is because of cardiac
And
yeah. So
most
that is
common cause of chest pain, as per the patient, is acidity, and the
yeah.
patient lands up in an emergency. It's basically an MI. So
Correct.
you land up in trouble if you're going to just give too many things. Another thing is that we give a lot of OTC stuff, and I think a lot of GPs use honey tests, and all those honey kind of stuff. Just remember one thing: it amounts to a criminal negligence on that count because you are not eligible to write an alternative medicine.
Ayurvedic
So that
drugs.
has to be
Right.
taken into account.
That's another thing that has to be taken. Is Dr. Kinjal?
Yeah, sir. So basically, what Dr. Vibhu said, just to add one more point, that yes, and the guidelines were there, and actually they said that basically you need to be trained for it, and then only you can do teleconsultation. But I think so. Most of doctors have not taken any training for it; they are just doing it. Till date, the Bombay High Court judges judgment still states that if you are doing any teleconsultation and if something goes wrong, you are liable. So that is what Dr. Vibhu said very clearly: be safe. So, if any doubt, ask them to go to another doctor or a nearby hospital and be careful because otherwise, if any problem occurs, you are going to be liable.
Yeah, and we got a proof of your text, and he can also show it to you and show it to the court and say, okay, this was given. So that would be a safe practice. We're also just taking basically simultaneously audience questions. So there is a question from Dayanand from Telangana. If suppose death has occurred during the case of MLC, how long to keep the records? So he's saying that if suppose, for example, there is a medical case of asphyxiation or something, hanging or something, and then the patient during the time of treatment dies, and he is a MLC case. How many days you'll have to basically keep the record? I think that Kinjal, you have already answered that, but if you can.
I'll repeat it if they want. The pertinent question basically is not related to death of the patient; is related to the
MLC
completion of
case. MLC case died.
right. So the case must have died, agreed. But till the date the MLC case is over, final judgment, till that time you have to keep the records. It is not related to the death of.
Normally, I mean, the MLC cases should be kept separately, and even if the judgment comes from a lower court, it may be challenged at the higher court. So you have to just keep it. I mean, more or less, you can realize if you have an MLC case with you, you have to keep the file for your whole life, at least till you are alive.
That's true.
And keep it with your property papers.
And even there is a practice, that I have got basically a colleague who's MD also in FMT, and he's also done a law. And he says that you call for any of MLCs, and he would just take it as like a primary consultant, and then he will do everything. Is it actually a good trend? I think we have got in our hospital, and we had actually a lot of help from them. So any MLC comes, you have to just call him, and he will, and a patient then will be under the combined admission of you both. Is it actually a good trend, or it doesn't help?
May I answer, sir? So there is one association called the Medicolegal Society of India. I am a member of it.
Yeah.
Run by very eminent people who are themselves medically as well as legal experts. So they do come picture, and even as a practice in Hinduja, we have a separate medical legal cell. So for helping us out for this purpose. So definitely they coming and putting as a consultant, or basically helping us out without being a consultant. Their help definitely
Joint admission.
Helpful.
Yeah.
Because they know legally where you might go wrong. Medically you may be correct, but legally what judge is going to see, what he is going to question, what are the points has to be mentioned on paper. All those things will be very nicely seen by the medical legal person. So taking their help will be definitely saving you from different troubles.
Yeah. So basically, he sees the file, and he also finds out lacunae in in his documentation, and then he would keep the file. So this is what is done, and I think that is very good. If you got a busy practice and you feel that you can't have this documentation, it's always easy for any of the MLC cases. What I'm saying is only about MLC cases. You can have his help. That is, I think, that can be quite helpful in also some of the situations.
Mentioned that we cannot change the once it has gone from hospital records, they have taken a printout and it has gone submitted in the court. We cannot change the records later on.
Yeah,
so whatever we done during hospital stay, records are out of the hospital.
Yeah, correct. So at only just time of discharge, he can
changing records is illegal, Dr. Modi. Dr. Modi, changing any record is illegal.
So you cannot
changing the records.
That is seen as manipulation.
We should keep it off the label what we are doing.
Agreed. Whatever has to be done before it goes to the court.
Yeah. So even after a patient is discharged, sometimes we are quite basically busy in helping the patient or also trying to save him. And then after that, once you have done everything, you should just spend some time and see whether you have just documented whatever efforts I think you have done. We got a very good advice which has actually come from Dr. Jayaraman from Tamil Nadu, that in Indian Medical Association we have some professional protection linked social security scheme, PLSS, and also indemnity policy. So I think that is a good. I think even as I was saying, that you should have good relation with your Indian medical associations, because they have got actually very good cell in that, and they just come and help you. So of course, a point is well taken, Dr. Jayaraman, from you. We will again, have some chit chat on this thing, that there is a question to Dr. Maniraman. Is actually keeping non-allopathic RMOs basically is also good, because they say that you should MBBS. What are the points? Because now we are seeing that government is also giving impetus to Ayush, and they want to promote BMS and all doctors. But NABH, so if you got the NABH accreditation, if any of you have got NABH accreditation in the hospital and within the inspection, they want only MBBS doctors. What is the basically right?
Actually, WHO recommends doctor to population ratio should be around 1 in 1,000. But in India, we have around 14 lakhs allopathic practitioners so far registered in the medical council. When only allopathic doctors means doctor population ratio is very poor, 1 doctor for 1,600 patients. But if we're adding Ayush practitioners, maybe Homeo, Siddha, Unani, and Ayurvedic doctors, that doctor to population ratio comes up to 1 in 834 patients. So despite that, we have a shortage in primary health center and community health center, especially in rural India. Even specialists are, it's very, maybe 5,000 specialists only available against the requirement of 22,000. So definitely keeping them in the primary health center and especially in rural India, it's going to be helpful only. With the increase in maybe BS and PG seats, definitely that ratio should improve. But they can issue medical certificate and death certificate, and they can prescribe allopathic drugs, especially because of the shortage of rural areas. And also several states has allowed Ayush practitioners to run primary health center and community health center also, like Madhya Pradesh, Rajasthan, Bihar, UP, Maharashtra, and Tamil Nadu. So they can prescribe medication, they can practice, but maybe the specialist services, it's not advisable. Definitely, it's going to have a medical legal issues.
Clinical clerkship, rather than RM or something, we would just give some more designation, like there's clinical clerkship or something like that, rather than just designate them as RMO. That is another thing that people do in the hospital when they employ BMS and all. A quick
questions we have. So now we suggest 20 minutes. 20 minutes, right?
Yeah, so basically we don't have much questions. So basically we are just trying to see. So I think a very important aspect is art of counseling. So any one of you can basically see, or I would just start with Dr. Datta. What is the art of counseling? The necessary points to be made while counseling the patients when you have basically a bad case, or or else for that matter, any of the case that you deal with?
Yes, actually, the term we should focus at is the art, because we are practicing medical science, but definitely art is involved with our practice. So effective patient counseling is a crucial aspect of medical practice. We cannot ignore that, and it helps in improving the patient's understanding, adherence, and the overall health outcome of the treatment. So there are certain points that we should keep note on. That first of all, in our consultation, we should try to establish rapport with the patient, and because we all know that the first impression is the most lasting one. So we need to introduce ourselves. We have to actually make eye contact and build trust, as you have also mentioned in your presentation, just to have a healing touch on the patient. And then we have to actually listen to the patient. So that is very important before going for the advice. So what is the patient's concern? Whatever patient tells is not the history. We all know what we interpret from the patient's version is the history, but we have to listen to the patient. So that is very important, and empathy should be impregnated in it. Actually, what pain the patient is going through and all. Then we have to, when we open our conversation, then we have to provide a clear information of whatever diagnosis is coming in our mind. So as a pulmonologist, I can give example of asthma, and it should not, in most cases, should not include any medical jargons. It should be as simple language as possible. So in case of asthma, what I personally tend to do, that instead of saying that you are suffering from an inflammatory airway disease, I just tend to say that inflammation is the process, and it is designated by redness and swelling. Inside your airways, there is redness, swelling, and that leads to the obstruction in your windpipe, and that brings about the symptoms. So that makes the patient understand it in a much clearer way. Then we have to discuss the diagnosis and treatment options. There could be many options, and then they explain the diagnosis, that asthma is you may have to bear with this diagnosis for your lifetime, and what is the nature of the disease and all, and outline the treatment options, then the need of inhalers, and this is the only option, long-term treatment for asthma, like that. Then we have to listen. Then we have to encourage questions. We have to encourage questions that after listening to our understanding of the disease and our depiction, that what the patient is trying to say, and then we have to provide clear, honest, and thorough answers to all those questions. Then the point of lifestyle and prevention is definitely there, and we have to address if there is an emotional or psychological aspect of the patient. We need to understand. Then about the expectation, what we have to set realistic expectation. If we are dealing with some disease like IPF, which we cannot tell that you are going to do better in future. This is a progressive disease. We are just trying to stop the progress, and so we have to set some realistic expectations. Yes, sir. Then ensuring follow-up and documentation and counseling is very important from medical legal aspect. Mostly, and when we are dealing with any terminally ill patients, and then this counseling sessions are very important in these cases. And then we have to respect the patient's autonomy and his choices. So that's all about the art of counseling.
And there is another question whether we should just stick to guidelines, and what are the usefulness of having up to date and sticking to guidelines. Is it a good practice? I think it is. Do you have any other viewpoint? Yes, Dr. Maniraman?
Yeah, adherence to the guidelines, usually, especially. Sorry.
Yes.
Adherence to the guidelines, especially they're using the generic medicines. These are the things going on now. Definitely, it can reduce the cost of treatment if using generic medicines.
The guidelines to be considered for treatment. For example, if you got a case basically of some case of pleural effusion, then of course you should have guidelines on how to treat pleural effusion. Is it quite mandatory to then go as per the guidelines when you're treating. I think that's a good practice.
Yeah, that's a good
Is it
practice.
Dr. Vibhu? You're on mute.
Yes, definitely. Yes, definitely. The guidelines actually protect you in the court of law. Let's be very clear on that. Because especially if you have a standardized guidelines like the BTS or the ATS guidelines, so you can easily produce them in the court, and you can be saved. And those guidelines also have the complications mentioned, so if anything goes wrong, they can definitely save you. So there's no issue with that. And I think with as far as the criminal negligence is concerned, I think most of these criminal negligences require, as I mentioned, the medical board or the certain government doctors or whatever. For that, they also ask as a doctor, they'll also ask you that you did such and such thing, on what basis did you do. And once you produce the documents, I think you are quite safe with most of the things.
Oh, yeah, so that is very important, in fact. And one question from the audience, which is from Dr. B.K. Gupta of Punjab, Ludhiana, is that if your patient goes abroad and he also wants to have a telephonic consultation, or his local family member wants a prescription, what would be the legal status in such a case? Kindly discuss. So what he's saying, that if suppose he's got a patient who's being treated by you here, now he has gone somewhere else, he has now landed up with some problem, and he is now asking you for the prescription. So what should be done? I think it depends on where he is, because even if you are going to give him some drugs, it's not going to be available there, and unlikely that he would potentially get the medication on a prescription.
I'll tell you, no, I think probably, sir has asked the question is, he wants a telephonic consultation or his local family wants a prescription. So what happens, this is a usual issue which happens in Delhi, Punjab and all, that, your family members, so somebody has shifted over abroad to Canada or whatever with their family members, and he was under your treatment for a pretty long period of time. Now, diabetes and hypertension and COPD, these medicines more or less remain same. So now they want, because the medicines are expensive over there, they want the relative to carry that medicine or to post them. So for that, you need a prescription, because the Indian Post is not going to send the medicines without a prescription. That is a issue which is there, and I think legally speaking, that is not feasible actually to give you a prescription. Ideally, you should tell that patient to contact a local doctor over there if he has gone for, because see, most of these people are going for longer period of time. They go for 6 months, 1 year types. So if something happens, then that has to be explained to them that, look, your prescription is there, you have a prescription which you are following. Before you are leaving, I can always give you a prescription for say next 3 months, but now within that period you should contact a local doctor and get in touch with them. Otherwise, you are actually doing something wrong in that way, that you are actually interfering with their counsel also, because you're you're actually treating somebody on someone else's land, which is not legal.
Yeah, and then also you're not allowed to practice there, and I don't think he will be honored, in fact, there unless, and of course, if so, he's just going for 4 months. I think you can give maximum for 3 to 4 months. I mean, you can't give
3 months
beyond that. 3 months, yeah. A very important question before we just wind up, from which has actually come from Ravi Doshi sir. He's asking, do we have right to refuse treatment to any patient, or do we have right to refuse to
so
a patient?
There are two situations in that condition. One is that if the patient comes to you in an emergency, you have to do the emergency treatment no matter what happens, even if he's your biggest enemy. You can't kill that patient. You have to save that patient no matter what happens. The second thing is, the patient,
you can't refuse a patient.
You can't refuse. In an emergency. In an emergency, you cannot refuse. I'll be very clear on that. Yes. Suppose it's a patient who's coming to you in an OPD, and the patient is stable, then you have a full right to refuse the patient. That fine. You can just refuse the patient, refuse to treat. That's a normal thing.
And there's also, I think, a court decision that doctors can refuse patients who don't pick up quarrel or who have got a history of doing some nuisance.
So as long as the patient is not blacklisted,
even I have also done it. In fact, I mean, a patient who has just created, you can have this list, and then we also circulate the patient's name. In fact, that he is that that he has actually created ruckus here, and then he may also go to another hospital. So of that, so if that kind of thing is allowed, I think there is no problem, because we are just private practitioner, and he can always go to government hospital. There is no problem. So government,
Hey,
of
he
course,
can go to anybody. He can go to
cannot
anybody.
anywhere, anyone. Yeah, that's true.
That's his
So,
choice.
so I think that before we wrap up, because we are already over due of time, I would like to ask you one question, and you can answer briefly. What would be the key that would just prevent medical legal cases on doctors? Key one or two sentences. I'll start with Doctor. I'll start with Doctor Vibhu.
Okay, so the key is document everything what you do. It's a very
Documentation.
straightforward. Documentation is the basic thing. Whatever you do, be very clear in whatever you are doing, and don't go overboard for any patient. Let's be very clear. Don't play with the emotions. Remember one thing, as I think Dr. Modi also said, आप भगवान हो सिर्फ तब तक जब तक वो बचा नहीं है. जब बिल
Correct.
मांगोगे तो आपसे बड़ा शैतान कोई नहीं है, और वो मर गया तो आप जल्ला दो. Let's be very clear on that.
Yeah. So you have to have also your limitations. Don't go overboard. Be also transparent, and also have documentation. Yes, Dr. Modi.
Yeah, sir. So the last things, what I think the people should take home from this lecture is, apart from documentation, speaking with patient, counseling them properly, telling them each and everything what is happening throughout the course of the the indoor status, and basically OPD status also. If you're good rapport with the patient and relatives, medical legal parts generally go on the very negligible side. That is what been seen in that patterns.
Right. So documentation, and of course a very good counseling. Counseling is very important. You have to just give them time to ask questions, and be also very, very transparent.
Right.
Yes, Dr. Datta. Your take, your points.
Yes, definitely. The documentation, taking proper consent wherever feasible, even doing the minorest of a procedure, and keeping empathy and good rapport with the patient, having good behavior. At the end of the day, that is going to pay.
And Dr. Maniraman, your words. Is he there?
Yes, sir.
Okay, so I think that was a very, very interesting interaction of a topic that we don't discuss, but which
just
is
got a message from Dr. Krishna sir that today we had about 983 logins on
great.
this non-academic topic. Non-academic, but I think highly significant topic for all.
Yeah, it's very significant. In fact, that they say that you should have a treatment which should also look good. It should not be just good, but then it should be good in also terms of patient's eyes. So you have to try to see that what you are doing is actually correct, and also document. I would now hand over to Dr. Vijay Kumar. Thank you all for sparing. We know that we are not traveling, but still you also spared time. I'm quite indebted for that, and thank you very much. I'll hand over to Dr. Vijay Kumar, who has joined, I think. Yeah.
Thank you, Swarnakar sir. You've done managed it very nicely, sir. Thank you so much, sir.
Sir, it was a fantastic discussion. So, any conclusion remarks anyone wants to add apart from Rajesh sir? Okay, please go ahead, and then we will close after the conclusion remarks. Anything anyone want to add? Okay.
Outpatient procedure.
Yeah, so I think we have already got the codes of
fantastic.
So I think we can.
Our but we request from our side that this kind of seminar should be very frequent, because medical legal cases are coming up very frequently nowadays. So the frequency of this kind of awareness should be there.
And I think
I totally agree with you, Dr. Kinjal.
And also we can have
you, because when we see in the western part, particularly US, what has happened is there are ambulance chasers, what we call the advocates as ambulance chasers. They will be displaying and promoting themselves outrightly to most of the patients who are getting discharged, and then they're in huge demand. Okay, they don't even charge from the patient. They take the cut out of the whatever, they get the sue from the doctor. That's what it happens. So with this, it's a brilliant webinar from all of you. Really appreciate on a busy day, Rajesh bhai, your leadership, is amazing, and everyone has contributed brilliantly to the webinar. Thank you so much from the CCI end. Thank you. Bijal, you can close it.